Okay, so today we're going to be doing a rotator cuff repair on my patient, and we have previously kind of talked about an interscalene block, but I wanted to just go in and get a consent for it. But before I even go in the room, I'm just going to go through the patient's chart and ensure he doesn't have any contraindications to this procedure. And so some absolute contraindications being patient refusal, which is not the case, coagulopathies, as well as infection at the site. Some relative contraindications would be type 2 or type 3 AV block, any type of allergy to any of these medications that we're going to be giving, or of course any bleeding or hemorrhage or anything like that, which he doesn't have any of that. And so we're going to go ahead and go in and meet him. So good morning, Mr. Parker. My name is Marley. I'm going to be an SRNA today in your case. Can you kind of just remind me what we're doing today? Right shoulder repair. Okay, so I'm just going to initial your right shoulder so we are all on the same page in the OR when we get you asleep. So I just wanted to kind of talk to you a little bit about the block itself, some benefits, risks, and alternatives to this. So some benefits, definitely some post-op pain control. That's the biggest one. You will get to PT faster, you'll have less IV medications, less oral pain medications, and you'll just be in a better state post-op pain-wise. Some risks involved with this patient. Anytime you introduce a needle to the skin, there is a risk of infection, there's a risk of bleeding, there's a risk of nerve damage, which I will be using a ultrasound to mitigate some of those risks, as well as a pneumothorax. But like I said, the ultrasound helps with that. Some side effects with this, there is something that's pretty common. It's called Horner syndrome. It is temporary side effects. They include some differences in your eyes. One might be more dilated than the other. You might have some facial drooping. Your eyelid might be drooping a little bit. You could have some nasal congestion or a raspy voice. That is temporary. Another risk for this procedure is the drugs and the location of where I'm going. It's pretty close to the nerves that nervate your diaphragm. So you could have some shortness of breath, but that is also temporary. An alternative to this case is we could just do general anesthesia just like any other surgery, but like I said, you wouldn't have the benefit of the post-op pain control from the block. Do you have any questions, concerns? He has consented to the procedure, so we're going to go ahead and get everything prepared and ready that we need. So I have my mask, my sterile gloves, and my kit. In the OR, I would have him positioned supine, his head away from the surgical site. I would ensure that he has all monitors on, including O2, pulse ox, EKG, any other indicated monitors for this case. And I would ensure we do a timeout. So right procedure, right patient, right side, all of that good stuff. And so all of that has been completed. So I think that we're ready to get started. So I'm just going to put my mask on and my gloves. And so first you want to identify any landmarks. So for this block, your big landmark is you first identify the cricoid cartilage, which is at C6, and you go lateral to the clavicular head of the sternocleidomastoid muscle. And so it's about in this region, and so I'm just going to double check with my ultrasound. So with this, you start lower around the clavicle and you do just roll up the neck. And looking at the ultrasound, you'll see middle scalene, anterior scalene, sternocleidomastoid, and then the nerve bundle here. And so once I have identified a good place, I would mark where my probe was, and we can go ahead and get sterile and prepare for the case. So I'm just going to hand that back to my assistant. So I'm going to do a big prep first so it has plenty of time to dry. Going all the way out, liberal prep. And with chlorhexidine, I'm just going to let it dry for 2 minutes. stay open. We've reused the paper a couple of times. Okay. Okay, so at this point, we're gonna say it's dry. I'm gonna go ahead and drape the patient. Ensuring that it is the correct site where we're gonna be going. I'm gonna go ahead and draw up my local anesthetic, about 2 mils of lidocaine, 1%. Just have that needle ready to go. I'm gonna go ahead and do my skin wheel. Feeling for the artery, I'm going to aspirate and inject a little skin wheel around the site where we're gonna be going. Okay. So that is done. Going to just prepare everything that I need. I'm gonna have my probe sterile. So I have this sterile gel. I'm gonna go ahead and put a little bit in the probe cover and have my assistant assist me with placing that. Okay, going to ensure that all bubbles are off of the top and that I have it secured. I will put a little bit of extra gel at the site and get this out of the way. So with my assistant here, she's going to set up my needle to the flush and the nerve stimulator that we're going to be using. I'm gonna go ahead and have her flush the needle, and for the volume for this procedure, it could be anywhere from 20 to 40 mLs. It just depends on the patient, and so we'll just see when we get in there. The drug that we're going to be using is 0.5% Marcaine. Okay? So I'm going to re-identify my landmarks, which they did come up well. And so I'm going to insert the needle, and it is a 22 gauge 5 centimeter B-bevel insulated needle. So I'm inserting the needle. The depth for this is going to be about 2 centimeters, so I'm keeping that in mind, and I see my needle coming in plane through that middle scalene muscle. As it approaches the nerve, I'm going to stop and have my assistant turn on the nerve stimulator to 0.3, please. 0.3. Okay, and I do see a good twitch. The hand and deltoid muscle, and that is normal. And so can you turn it down to 0.2, please? 0.2. Okay, and the twitch did go away. If the twitch was still there, then I would need to reposition the needle. It was just a little too close to the nerve. So some bad signs saying malposition would be a trapezius twitch. So can you turn it back up to 0.3, please? 0.3. Okay, and the twitch has returned. So at this point, I'm going to have you aspirate for blood. Aspirating. And there is no blood, and so can you administer 1 ml, please? 1 ml in. Okay, and so the twitch has ablated. So the twitch is gone, and so that is a good sign. And so at this point, we can continue with our administration of the local anesthetic. Like I said, it could be anywhere from 20 to 40 mLs, just however much it takes to bathe that nerve plexus. It would be in 5 ml increments with aspiration in between each injection. And so once that is complete, I'll remove the needle, hand this over, undrape the patient. This is post-induction, and so assessment of this block takes about 30 minutes to set up. So intraoperatively, some signs of a good block would be maybe less anesthetic use, less opioids, less pain medicine, but really the assessment happens post-operatively in the PACU. I would assess the adequacy of the block. And then at that point, I would just document everything and ensure that everything is taken care of and continue to monitor my patient post-op.